What I want to do is to go through in my first talk kind of an overview of what it is I do, the terms that I use. Sometimes my vocabulary is new to people. I don't think that'll be the case with this audience. But at the same time, having a chance to share this information with patients, to me, it's very hard to break the language barrier. You know, what I do is, it involves a lot of jargon. And the message is to people that the jargon involves their illness. And to me, the concept of empowerment is that they will learn what's wrong with them, they'll learn the terms, and not need to have consultants tucked away in a little town in Pocomoke, Maryland. All right, let's see if I can get this to work. The real issue is that the illnesses I talk about are not rare. There was a nice paper from NIOSH, thank you, in January 2011 that's updated their idea of water damaged buildings. It used to be that the estimates in the US are about 25% of buildings had either ongoing water intrusion or a history of water intrusion. They're now up to about 60%. And the whole concept in all of these illnesses that I face is that these illnesses are dynamic. They change day to day with exposure. So that if someone started with Lyme disease 2 years ago and has changed their HLA expression, and we'll get to what that means in a few minutes, they are going to be affected. If they go have a nice stout beer on Moody Street, like we had last night, wonderful stout beer, but the place was moldy. And if one of your chronic fatigue patients goes into that building, and you can see the discolored carpet, you can smell the musty smells, and it's busy, and the doors are in and out, and you say, how could such a building that's open commercially be making people sick? Well, it will. And if you went to the basement of the hotel we're staying in for this talk, and go around to the back corner looking for a chair to sit in like we did last night, you will leave the front area that is not going to make anybody I know sick and go around to the back, and it's musty as can be, and it's moldy. And for people who get mold hits, you have 2 minutes to leave, because there will be predictable changes in your physiology, so that even if you weren't originally a mold patient, and by the way, when I say mold illness, let me be clear that I define, this is an acute and chronic illness caused by exposure to the interior environment of a building with a history of water intrusion followed by growth of microbes, including fungi, but not limited to fungi, as also included in the list are actinomycetes, bacteria, primarily gram-negative bacteria, and mycobacteria, and, I think this is a run-on sentence, and inflammagens, including beta-glucans, hemolysins, proteinases, spirocyclic drymanes, volatile organic compounds. Did I say mannans already? The point is that this interior environment is a complex ecological system with multiple potential sources for inflammation. And those sources of inflammation will make people sick if they are damaged by innate immune responses from pre-existing illness. So when I say, what illnesses are we talking about? In a way, the names that we use, we bandy about, mold and post-Lyme and fibromyalgia and chronic fatigue, the idea is that they have a final common pathway. The final common pathway lets us identify the physiology of what is wrong with them now, because that's what we treat. It's not what was wrong with them in 2003 in Nantucket. It's what is wrong with them now. You will find, even in Boston, where we don't have any tropical reefs nearby, that some of your patients will be sickened by having purchased grouper and snapper and jack and maybe some barracuda, I hope not, from a fishmonger, and they eat the ciguatoxic fish and become ill. And one of the easy ways in your history to have some comfort is say, do you eat fish? And if they don't eat fish, you don't have to go too much further. But if they do, say, do you ever get sick when you eat fish? And say, oh yes, that week-old haddock I had in the restaurant made me ill. Well, that's really not the same as eating a tropical reef dweller, a predator, a piscivore, if you will, that made them sick acutely within 24 hours with primary gastrointestinal, cardiovascular symptoms, and skin symptoms that was followed by development of chronic fatigue and did not go away by itself over a period of 3 to 6 months. Those illnesses are there. Cyanobacteria illnesses are not unusual even in cold Massachusetts in summertime when the Ipswich River starts to dry up upstream from where the Ipswich River meets the Sound. You will find pools with cyanobacteria blooms even there. I can't talk about the reservoirs. When I was growing up in Wilbraham, I can remember that Quabbin Reservoir used to have blooms, and I have no idea what was in there back then. Didn't have the sense to ask. You will find people having exposure to shellfish beds in around Plum Island. I'm not talking about Plum Island in adjacent to Long Island. I'm talking about Plum Island around here where shellfish beds have been closed. They had Alexandrium blooms that make a brevetoxin, and brevetoxin 2, 3, and 9 make people sick if you eat those. We had a big to-do a couple years ago with Massachusetts DEP not disclosing the closure of shellfish beds to the public, and there it was on the NOAA website. It's fascinating. And if you think that this is a public health concern, people like me saying, be careful, let people know, make their decisions, and someone else saying, oh no, don't alarm the public. Now, somewhere along the way, someone's got to defend those with pre-existing health conditions.